Good afternoon, everybody. It's 5 minutes after the hour, and I'd love to welcome you to the Wednesday, 23rd of September 2020 edition of the Med Safety Exchange. Thanks so much for joining us. My name is Mike Hamilton, and I'm Medical Director of ISMP Canada. This webinar today is a production of ISMP Canada and CMERPS, and with contributions from all of our partners and in medication safety, and particularly you, the audience. The goal, as always, of these webinars is to encourage reporting, sharing, and learning of medication incidents and medication safety topics. It helps to bridge the silos in healthcare, and we do this so that we can all learn from each other. And you'll notice that we have switched from WebEx to Zoom, and this is both for internal consistency in ISMP Canada processes, but for also what we believe will be some really neat features we can deploy in future webinars. Things like video, which we'll try in this webinar, better audience Q&A, some polling, some quizzes, and some differences in design that we can deploy. One of the things that you will have noticed is that you must register before the webinar. You can sign any time as long as you're registered before the webinar. You must also use computer audio. We don't have the ability to offer phone lines. For best results, ensure your computer audio is sufficiently loud. You as audience members are automatically muted. It's also helpful to maximize the Zoom window to better see the slides, and your video is disabled. Presenters have the choice of whether to appear on camera or not. The presentation part of this webinar is going to be recorded and will, as always, be available on our website in about 2 weeks or so, along with links and other materials. One thing you will note is that the presenters do not have control of their own slides at this time, so you'll hear next slide, please, to trigger me to advance. To submit questions, find the Zoom toolbar, which is typically at the bottom or top of your screen, and you'll find a number of options. Chat option is disabled at this time. The raise hand option is either disabled or we're going to ignore it entirely. If you do want to ask questions, please select the Q&A tool and a panel window will open up. And you can feel free to submit any questions or comments via that tool. You have the option to submit anonymously. Just ensure that that little checkbox, send anonymously, is checked. Responses will appear in the Q&A panel, and questions will only appear in that panel once they are answered. Any questions we don't get to, we'll try to answer offline if we're able to, such as if they're not submitted anonymously. For this session, we're going to mainly use the Q&A process through this window. In the future, we'll look at having a running chat or a verbal Q&A. And now for today's overview. This webinar, we're going to hear about the cost of opioid losses from Canadian facilities. And we'll also explore an interesting program from Health Canada called Stop Illegal Marketing of Drugs and Devices program. And this is a program I first heard about probably about 18 months or so. And I've come to realize it's under-recognized, and it does some really important work. And I think it'll be very illuminating to learn more. And we'll also learn about some of the initiatives in the consumer reporting program. All the medicines we work with end up in the care and control of patients and consumers, and this work is a critical way of hearing their voice. And we'll finish by visiting the Observatory. We'll hear some updates from ISMP Canada's analysis team. And for the first presentation, I'd like to welcome our first speaker, which is me, hello, to talk about the loss of controlled substances from Canadian facilities. And this is from an article that our research team published last winter, back in February. And our research group is interested in diversions from facilities and other healthcare venues. And our paper was published in the CMAJ Open, and I'd just like to go through some of the work with you. At this time, we're rightly focused on the pandemic, but as our attention has shifted to COVID-19, we still receive these really sad reminders that the opioid crisis continues unabated, and in some cases has been worsened by the societal changes and community upheavals brought about by the pandemic. We can't forget that the opioid crisis continues to exact significant harm, and we need to continue our work in addressing this tragedy. The actual source of these opioids implicated in substance misuse and overdoses may indeed be illegally trafficked from elsewhere, or maybe synthetically manufactured in illegal laboratories, but there's really no doubt that a significant number of these opioids arise from healthcare sources. Most of us presenting or in the audience work in healthcare, and we have been involved in cases where some pills or tablets or vials or opioid goes missing. Our study sought to quantify exactly how much opioid is lost from healthcare facilities and the value of this loss, both to the facility and its potential value in the illegal market. So for some background, any individual or organization who produces, packages, assembles, or transports opioids is mandated to report a loss to Health Canada within 10 days. This includes drug manufacturers, drug distributors, hospitals, long-term care homes, veterinary hospitals. Health Canada does conduct checks of these and inspections, but data on hospital inspections is really quite scarce, as is in the community. There are some local regulatory bodies that also conduct inspections, but practices in the provinces and territories vary widely. Typically, police services or insurance companies don't necessarily enforce reporting, and they may actually not even be alerted to the losses. This is in contrast to the US, which has a large agency devoted to keeping track of opioids and understanding the opioids, both legal and illegal in the US. And as an example, the US averages a loss of about 12.2 million opioid dosage units a year, whereas in our data, it's about a loss of about 1.1 million dosage units. And this discrepancy is similar between the US and Canadian populations, which suggests that maybe the rates of opioid loss and theft are similar in the two countries. What we looked for when we were doing this work is the largest published data set based on the losses of controlled drugs. And we have to thank the Canadian Broadcasting Corporation for this. In June of 2018, they did publish a large data set of all controlled drug substances losses between January 1st, 2012 and September 30th, 2017. And we limited our analysis to the most commonly dispensed opioids, so a subset of the controlled drugs lost. So this was codeine, fentanyl, hydromorphone, morphine, and oxycodone. We also know that tramadol is, among the 6 most dispensed opioids in Canada and does go missing quite often, but it's not classified as a controlled substance during this time of study, so we didn't get any data on that. The data set is large, it's complex, and it's complicated. And it's problematic in understanding what exactly it's trying to tell us. So opioid losses are often reported in dosage units or incidents lost. So dosage units really doesn't count the loss quantities. So the loss of 1 tablet is counted as the same as 1 bottle containing 100 tablets. Likewise, incidence of loss ignores quantity completely and is also affected by reporting frequency. For example, Hospital A may submit a single report for multiple losses of a drug within a 10-day period, whereas Hospital B may submit separate reports after each occurrence. So there's significant reporting types of bias. It's also quite difficult calculating the actual dose lost. So the quantity lost may be 4 patches or 10 vials, but you need to actually do the math to calculate how many milligrams are lost for every reported drug loss. And then after we had done that, and for ease of comparison and standardization, we converted all of these numbers into oral morphine equivalents, or MMEs. And there are a number of loss reports in the data set that are quite ambiguous. For example, there are reports that listed the loss of fentanyl patches, but had loss amounts listed in milliliters. Or the drug loss was oxycodone, however, there was no reference to the tablet strength. Or as the example on the slide suggests, a loss of 728 packages of hydromorphone hydrochloride, 50 milligrams per mil. So you have the number of packages and you have a concentration, but you don't know how many of these vials or what size they are that are in the package. So in these cases, we looked at Health Canada's drug product database to see how they were marketed and packaged. And in all cases, really, we sought the most conservative approach to our calculations. For drug costing data, what we used was the Ontario Drug Benefit Database. And we used this because by far most of the oral morphine equivalents, MMEs, most losses came from Ontario. And if this cost was not available from Ontario data, we searched other provincial formularies. Calculating a street value was also interesting and problematic. The value fluctuates quite regularly depending on cycles of supply and demand, geography, both regional geography and even street-to-street geography. And certainly drug strength and types of drug packaging certainly influence street cost. But we did have significant help from the Ontario Provincial Police, and what we couldn't find from there, we did extensive reviews of the literature. And again, in the face of some of these ambiguities, we sought the most conservative approach. So what we found over the 5 3/4 years of the data set is that there are 142,420 reports of controlled substance drug loss, and that's roughly about 68 per day. Of these, 65,000 are related to the drugs under study: codeine, fentanyl, hydromorphone, morphine, oxycodone. And this is about 31 reports per day. In total, if you added all those up, that's 112 kilograms. And if you converted all those into milligrams of morphine equivalent, that's 177 million. And that's roughly 84,000 morphine milligram equivalents a day that go missing. And the cost is 8.7 million in wholesale cost over the total, which is roughly about $4,000 per day lost from pharmacies and facilities across Canada. And that reflects roughly a street value of $136 million. So significant numbers in here. And if you look at from where these are being lost from, this may be a bit difficult to see, but on the far end column, the total number in morphine equivalents, about 77% of losses are attributable to community pharmacies. So by far and away, the largest share gets lost from community pharmacies. And 17% of these are from companies, and about 6% are lost from hospitals. And you'll notice that places like veterinary hospitals, armed forces units, long-term care homes, almost 0% come from there. Now, rightly so, there is probably significant reporting bias. Maybe there's under-reporting in some and over-reporting in others, but the differences here are really illuminating. The mechanism of loss is also very interesting. It varies within each context, and certainly notably in community pharmacy. Armed robbery and break-in entry are significant contributors to this. And frankly, we were very surprised to come across this. And it really means the challenges in community pharmacy may require an entirely different set of strategies to mitigate the problem of opioid loss than you would in a long-term care home or a hospital. And we're also keenly aware of the number of unexplained losses and the need for more tools really to help people sort of sort out why these went missing and where are they. There's, in a complex data set like this, there are a lot of limitations. And certainly I've talked about reporting, both underreporting and overreporting, number of anomalous reports. And our costing estimates certainly were very simplified point in time and very, very conservative. So in conclusion, what we think this study highlights is the opioid loss in terms of dose and cost. And it underscores there are different mechanisms of loss that will require different approaches to mitigate, and really highlights the role of community pharmacy here. And it's certainly the challenges in community pharmacy that are very different from what we know in hospitals or facilities. And there's very much a need to better understand the mechanisms behind this. And we believe that this work, although it's related to controlled substance loss, has implications for other work in medication safety. In reality, controlled drugs are the drugs we're supposed to be developing very robust policies for, watching carefully over, taking account of, keeping track of, checking, documenting. And yet in healthcare, we lose over 84,000 milligrams of this stuff every day. And if we can improve the processes for controlled substance, I'm sure that a lot of these ideas will translate to other aspects of medication management. So what I think are the key learning points here is the opioid crisis continues to exact significant harm. And the amount and value of controlled substance loss from facilities is very difficult to quantify and likely very much underreported. And for a med safety exercise, ask yourself, does your facility calculate the yearly loss of opioids? Do you have a sense of how much your pharmacy or long-term care home or hospital loses in terms of the cost or street value? And we published the ways we calculated these in our paper, so feel free to use those, and certainly let me know if you did, because I think it would be very interesting, illuminating work. So thank you. And before we turn our attention to our next speaker, I'd like to present this video that hopefully frames the next presentation.
Canada is facing a national opioid crisis. Part of the problem is that marketing by industry can influence how often opioids, other drugs, and medical devices are prescribed or recommended. Some of this marketing could be illegal. Did you know that Health Canada launched an online portal to help address this issue? This portal has information that will help you better understand what is and is not illegal marketing. We have also created an easy online tool to report suspected illegal marketing practices to better protect your patients. Want to know more? Reach out. We want to hear from you. You can help stop illegal marketing of drugs and devices. You report, you protect.
Dr. Alain Musende has a PhD in pathology and laboratory medicine and is manager at the Marketed Health Products Directorate for Health Canada, where his team leads the oversight of regulatory advertising activities of marketed health products. And we're very pleased to have him speak to us about the Stop Illegal Marketing of Drugs and Devices program. Dr. Musende, welcome. Please unmute yourself and let me know when to move your slides.
Thank you very much, Dr. Hamilton. It's my pleasure to be here, and I thank all the participants to join us who have shown interest in knowing more about all the presentations that will be here today. So next, please. So the purpose of this presentation are really threefold. So first, to discuss with you the oversight role of advertising of health products that Health Canada carries and performs. And second, then we're going to focus specifically on that program that was on that video, the Stop Illegal Marketing of Drugs and Devices, in short, and henceforth, I'll refer to them as Cmdd. I presume some of you may have recognized yours truly on that video, and the other actors, actually my staff. And the key purpose of that video is it is intended to be disseminated to healthcare professional organizations so that they can make it available to their membership in order to promote and to popularize this video. So the last aspect of the purpose of this presentation will be to discuss with you our transparent approach to compliance and enforcement when we find problems with marketing of health products. Next, please. So first, as I said, we're going to focus on Health Canada's regulatory advertising oversight. Next, please. So this role that we perform, we don't do it alone. And we have key partners, key players while accomplishing or performing our role. So this depiction essentially lists some of the major players. So with Health Canada, you have in purple, pink color, the APA, which stands for Advertising Pre-Clearance Agencies. These are agencies that essentially pre-clear advertising materials before they are disseminated to the intended audience, whether the public or healthcare professionals or any other audience. And then on the right, you have industry associations. So it is the responsibility of industry to ensure that their advertising materials comply with the law, the legislation and the regulations. And at the bottom, you have you, the healthcare professionals. And you play an important role in reporting to us advertising or marketing activities that you encounter or you are exposed to that may be problematic, so that we can look into that and take actions. And there is the general public. They too report to us extensive numbers of advertising on TV, newspaper, etc. Next, please. So what is our role as the regulator, Health Canada? Our roles can be broken down into four parts. So first, we are the National Regulatory Authority for Health Product Advertising, which means that we deal with and we lead everything health product advertising. We set the parameters under which a health product can be advertised in Canada, meaning that we work on the terms of market authorization when the product is authorized for sale in Canada, documents such as the product monograph. So advertising can only be, a drug or a health product can only be advertised within the parameters of the terms of market authorization. We also, of course, produce, develop legislations, regulations, and associated guidance documents which explain this legislation so that anyone who wants to advertise, especially industry, are familiar with the requirements. Next, please. So the starting question is always, why does Health Canada regulate the advertising of health products? There are many reasons to that, but the main one is that because it's mandated by law. We have to do this. There is the law that requires that Health Canada performs this task. Next, please. And the fundamental law, the starting law, is actually the one that defines what is advertising. So it defines it as any representation by any means to promote directly or indirectly the sale of a health product or food or cosmetic or device. Okay, next, please. So what we see here, the word any means and indirectly that are underlined. So any means, this legislation, the Food and Drugs Act, was drafted and promulgated some 50 years ago. But it is still up to date in the sense that by any means, it includes all the novel media platforms that are there, social media, anything going from TV, newspaper, etc. Everything is captured under any means. So it's applicable in the definition of advertising. Second, advertising is not always direct. Like we see in TV, on TV, there is a product there being promoted. Buy this, here are the benefits, this is what's gonna do for you. Advertising can be much, much more insidious, much more indirect. And even indirect, advertising is captured in the Food and Drugs Law. Next, please. So we have many provisions that use for advertising, 10 or more. However, I like to, for you, the key message for you to know, what are the requirements broad? What does the law says about advertising health product in Canada? So I take these two key provisions and I will discuss them in a storyline format. So starting with section 2, which defines advertising. Next. Then what we are saying is, okay, once you understand what advertising means, now you can advertise your product, but your product must first be authorized for sale in Canada by Health Canada. That's the next provision. Next, please. And then once your product is authorized, you can proceed to advertising it. However, your advertising, your marketing must not be false or misleading. This essentially closes the loop. Next, please. Next, yeah. So within that framework, there are 3 key considerations that are in place. The first, we recognize that not all messages about a drug or a health product constitute advertising. And this is an important distinction because we have like educational materials about a health product and a medical condition that should not constitute advertising. So it should not be regulated by law and those restrictions. And the second thing to consider is what I already discussed, that advertising must be consistent in accordance with the terms of market authorization. And finally, advertising is audience-based. The product is being advertised to the general public. There are some restrictions that are not applicable. For example, if it's being advertised to healthcare professionals, that's sophisticated audiences like the healthcare professionals, formulary representatives, insurance company representative, and so forth. Next, please. Okay, so when it comes to advertising to healthcare professional, which is this audience is about, all products, all health products can be advertised to healthcare professionals, from medical devices, biologics, veterinary product, prescription drugs, everything can be. However, there are 3 key requirements. The first one is that the product that is subject to advertisement must first be authorized for sale in Canada. Because if it's not, then the benefit and risk, the safety profile, the benefit and risk profile of this product is unknown. So it must first be authorized by Health Canada. Second, the product that is being advertised, the advertising itself must have sufficient fair balance of benefit and risk present in the advertising. And finally, if there are additional terms and conditions added to this type of product, like particularly now with the opioids, then that too must be conveyed as part of the advertising. Next. Okay, so now the second part of the presentation will focus on the Cmdd. Next, please. Next. Okay, so thanks, Dr. Hamilton. So here we define what the Cmdd is. Essentially a web-based program. Okay, thank you. So what are the goals of the Cmdd? So it has 3 main goals. First, to educate healthcare professionals on detecting or suspecting illegal advertising or marketing. Second, it provides them with a quick means of reporting this false or illegal marketing. And finally, it also intended to help educate healthcare professionals so that and encourage them to not be involved or engage in false or misleading or illegal marketing or advertising. And this is a serious issue because we see that very often across the country. For example, advertising of Botox by clinics across the country. This is illegal advertising of Botox. And we also see healthcare professionals making false and misleading claims when promoting some of their services or devices, usually services associated with devices. But often, some of these healthcare professionals were not aware that they were actually misled by the manufacturer of this product. Next, please. Okay, so the drivers, there are two key drivers to this initiative, what drove this initiative. The first one was that there was a standing committee on health which was looking into addressing prescription drug abuse in Canada. And there were many witnesses, including healthcare professionals, who participated in this. And at the end of it, there was one important recommendation for us, which was that the committee was asking Health Canada to review inappropriate marketing practices that have an effect on prescribing practices. So as we know, the main marketing approach that impacts prescribing practices is, of course, advertising targeting healthcare professionals. That's why the Cmdd caters primarily or almost exclusively to healthcare professionals. Next, please. And the second driver was regarding the opioid crisis, as Dr. Hamilton discussed in his presentation. So during that crisis, Health Canada had to take a number of actions. And one of the actions was the recognition that marketing of opioids to healthcare professionals may play a role or may contribute to the crisis. So the Minister of Health decided that a dedicated team must be created to proactively monitor opioid marketing. Now, opioid marketing, it is illegal to market or advertise opioid to the general public. This advertising, this marketing occurs only to healthcare professionals. So hence, again, we created a Cmdd because some of this marketing between industry and healthcare professionals happen one-on-one. And we have no way of having that information unless we collaborate. We reach out to healthcare professionals through the Cmdd, for example, so they can alert us. Next, please. So how has been this product, this program, how has it been working for us? Very well, actually. We launched it in March 2019. And to date, we have a total of 328 reports of incidents that have come to us through the Cmdd program. And when we look at this year alone, it's roughly 89, with 29 that are focused on COVID related, and about 58 or so that are non-COVID related. Next, please. Okay, so when we break down this by-product line, we can see that since March 2019, biologics lead the pack with nearly double the amount of the next one of the natural health product. And then we have the medical devices and so forth. Even reports on food-related advertising associated with some health product, which is interesting. Next, please. So we also track the visits, the web visits on this product, which is an indication for us to look at the interest that people in general, organizations around the world may have on this product. And as we can see, Canada leads with 29,000, followed by the US and India and the UK. But these are the top 6. The list is far longer. So, but we decided to play the top 6. It's great because in the audience today, I understand that we have international participants, which is good. So it also reflects the global nature of the pharmaceutical industry and healthcare, health product advertising or marketing in general. Next, please. Okay, and nationally, we also track that with Ontario and Quebec and BC leading the pack. And it's interesting because last year I gave a similar presentation to the New Brunswick Dental Association. And I told them, well, look where you are ranked, and I hope you're going to improve your game so that you can catch up to Ontario. It was a nice discussion, and I really appreciated the opportunity. Next, please. And when we focus on the COVID-19 related complaints only, we can see that pharmaceuticals to date are leading. People may be asking, wondering why. Are there prescription drugs involved there? No, these are primarily over-the-counter drugs and led by disinfectants, many of which are over-the-counter pharmaceuticals. So we're going to continue monitoring this, and we expect this to increase again as we go by next year. Next, please. We also track what interests people once they land on the Cmdd webpage. For those who have not visited that web platform yet, it is really a very good summary of how Health Canada regulates all the marketing and the advertising of all health products. So very, very informative. But we track the search name for us to see if there are things that are not there that we can add and include there. And when you look at the search name, we receive this report on a monthly basis. So in August, for example, hand sanitizers constituted the top search. Not only just hand sanitizers, if you go down row number 6, you see recall hand sanitizers. This may have been linked with the media reports of the recalls, especially in the US, of hand sanitizers that were containing methanol. So we can see those trends happening when people are going even on the Cmdd. Next, please. So we are hoping that we're going to benefit from the Cmdd in many ways, not only to deal with the issues that are being reported to us, but more importantly, to identify trends and growing issues. And when, for example, there is a high profile health product related marketing issues or litigations, like in the US, what happened there in 2012, we had GlaxoSmithKline, which pleaded guilty and paid $3 billion for a number of offenses. One component of that was the misleading advertising or marketing of antidepressants to health care professionals being prescribed to kids under 18. So when these type of things happen, the media picks it up. We are asked the question, is it happening in Canada too? Same drugs, same companies, both sides of the border, what's happening here? So we can turn to the Cmdd to see if we have noticed these trends coming up, and we'll be in a much better position to explain in an evidence-based approach whether or not this may be happening in Canada, and we can investigate. Next, please. So when we see incident, we identified problematic marketing that are non-compliant. How do we go about dealing with that? Next, please. So we have a gradual approach in dealing with non-compliance and in applying our enforcement. We always start by requesting immediate compliance. The company must stop immediately the marketing or the advertising that they were engaged to. Generally, we would achieve compliance. We can educate them, work with them, inform them. But if we are facing willful non-compliance, we can escalate the situation to the point where we can go to court, seek an injunction, or recommend prosecution. Next, please. And what we do, we keep it transparent across the board. Here you see a table that we publish on a quarterly basis every 3 months that lists all the product that and the advertising that have been problematic and the action that we have taken. It's available to the public. Anybody can access that. And right now, under the COVID-19 situations, we have a table, similar table, but dedicated to COVID-19 issues only. Next. So I thought to wrap up this session, I'm going to present you with a small case that is a tangible type of representative of the work that we do, so that you can see a practical example. Next, please. Okay, so this is one of the case, I would say one of the simplest case we dealt with when it comes to advertising directed to healthcare professionals. This ad ran in the Journal of Rheumatology in 2018 and many months in 2019. What is very interesting is that the ad reads, next up in our rheumatology pipeline, upadacitinib, a JAK1 selective inhibitor. So it clearly says next up in the pipeline. So next, please. What happened then is that this product, it's next up in the pipeline. It's not authorized by Health Canada for sale in Canada. Because of that, advertising this type of product or marketing this type of product is illegal. Okay, next, please. So we had to take action. We contacted the company and asked them to immediately stop running that ad until that product is advertised and the advertising will comply with its terms of market authorization. And the company, of course, complied promptly. Next, please. Okay, so in conclusion, Health Canada, really our main fundamental mandate is to protect the health and safety of Canadians so that they are in the position to make informed decisions about their health with you, the healthcare professionals. And we always aim and we are hoping to work closely with healthcare professionals and other stakeholders to achieve that goal. Thank you very much.
Thank you so much, Dr. Misende. Very interesting and a very, I think, useful program that we should pay more attention to. So, I mean, there's so many key learning points here. A couple I picked out is health product advertising is subject to restrictions on marketing and advertising, and the Cmdd program is set up to educate, receive reports about illegal marketing and advertising, and investigate contraventions. And I think for all our exercise is something quite simple. And the first one is to visit the website and learn more about the program and peruse some of the reports and learn how we can contribute and how we can learn from that. And the second one is when doing MedRec or other medication reviews, and especially when coming across an unusual health product or a medicine that's used in an untypical manner, consider whether or not this product may have been illegally marketed. So I think there's lots to think about in your presentation. So thank you very much.
It's my pleasure. Thank you.
Great to have you. Next up, we'll hear about the progress in another reporting and learning program, Safe Medication Use.ca. So Melissa Sheldrick, you're unmuted, so please go ahead.
Thank you, and good afternoon, everybody. My name is Melissa Sheldrick, and I'm a patient and family advisor here at ISMP Canada. And it's my pleasure to be here with you today to share with you an exciting update to our medication error reporting program for consumers. I will be putting some links in the chat box at the end of the presentation for more information. Next slide, please. Medication errors occur in all sectors of the healthcare system, and they are causing harm to patients. We know that medication, and sometimes multiple medications, are used by Canadians on a daily basis, whether they are prescription or non-prescription, and we need to work together to make medication systems safer. In fact, 2/3 of Canadians over the age of 65 take at least 5 different prescription medications. Incidents that occur during the prescribing, dispensing, and administration processes are the second most common type of adverse events in hospitals. Next slide, please. In 2010, the Institute for Safe Medication Practices Canada created a medication error consumer reporting and learning website called Safe Medication Use. And the goal of the website was to inform consumers about medication errors and how to prevent them. Error reports have been submitted over the past 10 years through the website. However, the number of reports submitted have been fairly low, and most reports are coming from 8 provinces. Next slide, please. As stated by the Canadian Patient Safety Institute, patients and their families are too often passive recipients of medicines and not informed and empowered to play their part in decreasing the risk of medication errors. The 2006 Institute of Medicine report, Preventing Medication Errors, states, the most powerful strategy for improving safety may be motivating providers and organizations to support the full engagement of patients and surrogates in improving the safety of medication use. In early 2019, ISMP Canada reached out to CPSI and Patients for Patient Safety Canada to collaboratively develop and launch an initiative to increase the quantity and quality of medication error reports from consumers. The goal was to receive more information from consumers on what medication errors they were experiencing and what they believe is needed to prevent a similar error from occurring again. About a year ago, a group of passionate patients, medication specialists, and representatives from national patient safety and other organizations from across the country came together to tackle the challenge: how might we engage the public to share medication error reports in order to prevent others from having similar events? Next slide, please. A sprint workshop is a 2-day event where we try to solve a complex problem in a short amount of time. It is a co-design model between patients, practitioners, and other organizations where we take time to really understand the problem, bring ideas to the table, and then build prototypes so that at the end of the workshop, there's a concrete starting point from which we work towards the goal. One of the prototypes that was developed was the platform for reporting errors. With that prototype, mederror.ca or errormed.ca was born along with a proposed robust awareness campaign. Next slide, please. Mederror.ca and errormed.ca were crafted carefully to maximize the ease of use for the consumer. Since our main goal was to increase the quantity and quality of the reports received, we needed to ensure that the purpose and layout were clear, the content was in easy to understand language, and that the graphics added to the site but did not overwhelm it. As you can see from the home page, the site looks clean and easy to navigate. Next slide, please. Clarity of the difference between a medication error and a reaction or side effect was an important consideration when designing this website. ISMP Canada does not collect reports about side effects. However, on our homepage, there is a mechanism built in to link consumers to Health Canada's Vigilance Program. Should a consumer mistakenly report a reaction as an error, ISMP Canada can ensure that the information is provided to Health Canada. The consumer perspective is critical to improving medication safety and preventing harm, and we are committed to facilitating the collection of all reports to further this work. It is important for consumers to know that their report is acted upon when it is received. The analysis team at ISMP Canada looks at every incident that is entered into the system, and there's often learning that is gleaned and shared through newsletters on safemedicationuse.ca or through our social media feeds on Twitter and Facebook. In the top right corner of this slide, you can see real-life examples of change that stems from consumer reports, and this information is embedded into the website. When consumers see that their voice is heard, valued, and acted upon, they are more likely to continue to share their experiences. Analysis from both of those cases resulted in system change, a testament to the value of reporting, learning, and sharing. Next slide, please. In creating a user-friendly website, our team looked at the existing reporting form where consumers provide information about the medication error and we decided that it too needed a refresh. The questions have not changed too much, but the wording has followed a plain language guidance, and they have been reordered so that the required information appears at the top. This will ensure that there is enough information presented to be able to analyze each case. There are definitions that are provided in hover over choices to ensure the clarity of what is being asked. Another important consideration was to allow consumers the space to write as much detail as they are able and willing to. We also give the reporter the option to leave contact information, which helps if we need additional information to properly analyze the error or to follow up. Every report that is submitted is read and interpreted to determine what happened and how to prevent the error from happening again. Also, we sometimes request permission to use the patient's de-identified information to highlight important lessons learned. When asked, patients often have ideas about how to prevent recurrence, and this perspective is invaluable. Patient reports often directly inform safe medication use newsletter topics that are produced and shared approximately 10 times per year. You can sign up for our consumer-facing newsletters at www.safemedicationuse.ca. Next slide, please. Creating mederror.ca and errormed.ca has been a true team effort. Patients, practitioners, and patient safety experts and others have come together to offer consumers an opportunity to not only share their experiences, but to learn about preventing harm from medications. Together with our partners, the Canadian Patient Safety Institute and Patients for Patient Safety Canada, we are proud to launch this new website to consumers, and we hope that you will help us spread the word. Thank you.
Thank you so much, Melissa. Very powerful work, giving consumers a voice. And next up, we will climb into the observatory for a quick, very quick update from ICP Canada's analysis team.
Hi there. Good afternoon, everybody. My name is Dorothy Tsin. I'm the Director of the Practitioner and Consumer Reporting and Learning Programs at ICP Canada, and I'm a member of ICP Canada's analysis team. Over the next few minutes, I'll be sharing some highlights, an important highlight from our analysis team. Next slide, please. Over the last 6 months, many of you have reported to us your experiences, concerns, and medication errors related to the COVID-19 pandemic. And in turn, as Melissa has shared, we've shared that learning from these unique circumstances, from the complex introduction of new products like double-strength propofol to hospital medication use systems, to the recognition of poisoning risks associated with hand sanitizers packaged in water and wine bottles. So over the next few minutes, I will be sharing another COVID-19 related issue, a dangerous practice that has recently come to our team's attention. Next slide, please. So in this case example, a concerned parent reported to our consumer reporting program that her child vomited after receiving her first dose of liquid antibiotic. So as you know, this in itself isn't that unusual, but the story that follows is. So this medication is available in powder form and requires the addition of distilled water to create the antibiotic suspension. This reconstitution step occurs in the pharmacy before the product is handed over to the patient. The parent reported that a short time after the first dose was given to her child, the pharmacy that dispensed the medication called to ask the parent to check the antibiotic. When the parent smelled the product, she noted a very strong vinegar smell. This information prompted the pharmacy to believe that vinegar instead of distilled water was accidentally added to the antibiotic powder. In addition to this case, we've also received reports from community pharmacy team members who've identified that cleaning products are being stored in bottles that originally contained distilled water. In one case, although a bottle containing diluted bleach had its original water label removed and a label with the new contents applied, it was still mistaken for distilled water. Fortunately, in this case, this was recognized before any dispensing errors occurred. Next slide, please. This slide shares some preliminary findings from the analyses of these incidents. So we recognize that pharmacies are undertaking more frequent cleaning and sanitization of services because of the pandemic. And due to the increased volumes of cleaning products being used, these products may be purchased in larger volumes than usual. So pharmacies may be repurposing these empty distilled water bottles, like the example shown in the right picture, to house diluted cleaning products like the bleach or smaller volumes of cleaning solutions. And despite relabeling of the bottle with the new contents, staff who are familiar with these bottles are still expecting distilled water to be contained within. And storage of these repurposed bottles in areas of the pharmacy where distilled water is normally expected further increases the risk for misidentification. So to prevent accidental reconstitution of medication cleaning products, ISP Canada shares these recommendations. Firstly, never to use repurposed distilled water bottles to house cleaning products. If for whatever reason these bottles need to be reused, they should only contain non-toxic products. And the bottles should be, the distilled water labels on the existing bottles should be removed from the bottle so that it doesn't display water as the content. The bottles should also be labeled on multiple sides so that when a staff member interacts with the product, a label is always visible. And the bottle should be stored outside the pharmacy dispensing area to reduce the risk for misidentification. Next slide, please. We're thankful for the parent who reported the error and the community pharmacy teams who identify these risky practices. We ask that you review your own workplaces, regardless of where you practice, to see if distilled water bottles are being repurposed to house cleaning products and to take the appropriate actions to stop this dangerous practice. Thanks for your time.
Thanks so much, Dorothy, and all our presenters for the terrific learning that we had today. We'd also like to thank both them and you, the audience, for learning along with us about the Zoom webinar platform. Please let us know what you think about it. Please let us know how you can make it better. We hope to incorporate more features in the future. I always want to hear from you. If you have anything you'd like to present, we have this brand new platform for you to do so. And certainly we can make it so that you're anonymous if you're more comfortable with that. Please let us know, send us your ideas at medsafetyexchange@icimpcanada.ca. And please join us next time. We'll solidify a date towards the end of January 2021. And please keep connected with us. Thank you for participating. Please, all of you, enjoy the rest of your day.